to realities. I think that, is that the point you're getting to?
Yeah, but to that end, for instance, at the Ontario Medical Center, there's one person who has done 75 symphonies last year, and another person did 5. So same patient population, same pathology, and then if you talk to the person doing 5, he says, it's too much of a hassle. I gotta talk to the patient, and as this doctor said, follow them for a long time. I just don't have the chair time. I think more than anything, it's the hassle and the lack of incentive that's making our rate lower. You're right, it may not be 16% in the community. It should be 16%, but I think more than anything else, it's the chair time that we don't have, and probably the lack of incentive that's driving these really low numbers.
And then what I would say to that is we have lots of specialists in this room who do things that take a lot of chair time with no incentive.
True.
And I'm not saying that the chair time is the thing that's
Well, it's that
holding
kind
us
of
back.
seems that you're saying that incentive is the main barrier.
I think I believe that is a huge one. Yes. Sure.
For me personally, to reduce my chair time, I say something like this. Well, you can, if you don't mind halos and you can't need glasses for intermediate, and you want to pay $2,500 and have both eyes done, then you're the candidate for this. And then most of the time they go, forget it.
So
But if they say yes, every one of them is happy, right? Because they get past that, right? That's not.
sure. Okay.
Hold on, let's Blake finish the slides first, because we're not gonna forget the questions, and we're not gonna forget the answers. Let's plow through first.
Okay. So just as just to go through the numbers. So we're charging $2,500 per multifocal. We said already that it's about $900 that we pay the company for the lens, and right now we're getting about half an equivalent, I believe. So that's about $120 for the surgeon. So that's still, that remainder is still $1,480 that is left over for the partnership and for the health plan. Right now, as it
Also,
stands,
don't forget
Huh?
that they're a nonprofit entity, so they don't pay tax, but that 120 is not to pay tax on it.
It's true. So actually, yeah, after taxes, which is like 40%, we get about $80. Okay. So yeah, I agree. Thank you. So we're getting $80 per lens. We're charging $2,500. Now, outside of Kaiser, the compensation for the physician is usually, I would say, like 30 to 50% of the cost of the lens goes to the physician after the cost to the pharmaceutical or whoever, and sharing it with the practice. That's what they go home. So we're getting less than 5% of our, and this is something that we as the physicians are advocating to our patients. So it is a little bit low, and that may be a reason why. Now, I'm not saying that's definitely 16% of the community. There may be a 3 or 4% less because of using lenses on people who shouldn't get them, but it's still significantly higher even with people with no pathology. So, just so we know the numbers. So if using the 2018 that I just mentioned, if it's $1,480 for SCPMG and 229 multifocals were done last year, the partnership made about $339,000. Okay. Now, if we were to increase our output by even 1%, remember I said our percent for 2018 was 0.57. For 2019, it's projected to be 1.2. Even 1% increase would add to, using 40,000 surgeries done, it would be 400 multifocals more, which would add up to just $592,000 right there, just by increasing it by 1% from our very robust 1% usage rate. Now, let's just say if we increase the multifocal compensation for the physician. Now, by the way, I'm not advocating, this talk is not so that us physicians can get more money. It's honestly because we are hearing and we know that we're a partnership, we need to survive, and we're competing against the outside market, and we should try to embrace any way that's ethical to help that. So assuming we go from 120 to 240, just one equivalent, okay? I am confident that would increase probably the percentage of lenses used. So let's do another calculation. Now, if we go from 120 to 240 per lens, just one equivalent versus a half, that goes to $1,360 per lens for the partnership. Now if we increase it by 1% using that model, it's about $544,000 extra. Remember, 2018 multifocals generated $338,000. So now we've already increased it to an additional 544 if we just go up by 1%. Given that there are 113 cataract surgeons in our group, let me see where I was going. Oh yeah, on average, each surgeon does 353 surgeries a year, 2 of which were multifocals, according to the 113 out of 229. So 2 out of 353 were multifocals on average for all of us. If we each did 0.33 multifocals more, it would make up for that going from a half equivalent to a full equivalent, if that makes sense. To make up for the lost income to the partnership by increasing it from a half equivalent to a full equivalent, each surgeon would have to do 0.33 more multifocals, or 1/3 of us would have to do 1 more multifocal a year. You want me? I'm trying to save questions till the end, if you don't mind. All right. So now imagine if we have a 5% increase in the usage of these lenses, which I still think which is still drastically lower than the 9-15% that we mentioned in the community, and so that would be 2,000 multifocals out of the 40,000, which would be about 17 to 18 multifocals per surgeon a year. This would generate $2.7 million more for the partnership. And I honestly believe that, like some of us were saying, incentive is a big reason why we're doing 2 a year per surgeon. And so by just going from a half equivalent to 1 equivalent, if we can even increase our output by 5%, that's $2.7 million for the partnership. Now let's, for fun, say that we increase the compensation. We're still well below what the community does. So $500, let's say, that the cataract surgeon gets for doing a multifocal, okay? It's still $2,500 per lens. We're not changing the price for the patient. It's still $900 to the company that we buy it from, and now you're subtracting $500 more. So now it's $1,100 per lens for the partnership. I'm confident doing that. If you were to say, and I know we all want to believe that we're very moral and we would push these lenses, not push, but be more advocating of these lenses despite any kind of incentive, but human nature is human nature. If we got our number, just for an example, to 10% of our cataract surgeries to multifocals, that would be a $4.4 million increase for the partnership. So,
Your last sentence there.
oh, well, I was just saying if people thought, oh, that's too much for the cataract incentive program, we could maybe move out of that cataract incentive program for this particular lens. All right, so ethics, number one, I'm not talking about increasing any cost to the patient, okay? We're already saying it's $2,500. I believe it's a disservice not to discuss this lens with a patient, especially if they don't have any underlying disease. So for my patients, what I do is I basically tell them if they have no disease underlying, that if you want to do a monofocal for distance, that's fine. Just be aware that you're almost for sure going to need reading glasses. And a lot of them, don't quite understand what that's going to be like. So I say, look, every time you want to look at your cell phone, every time you're at the store and you need to read the label on the can of soup, you're going to have to put on those readers and take a look at it. Or if you don't feel like doing that, you'll still might have to wear a bifocal, because a lot of patients complain, oh, I don't want to have to put them on and off all the time, right? I'm sure we've all heard that. So they want to get a bifocal so that they don't have to do that constantly. And I say, it doesn't guarantee that you're not going to need readers for fine print, but you will be much, much less reliant on glasses. This is obviously if they don't have some underlying astigmatism, irregular astigmatism, etc. And it's really important during the informed consent at the consult to really address their expectations so that afterwards you don't have that patient coming every 2 months complaining. Because actually, for me, I've done, I think 30 or 40 of these, and I've had 0 patients coming back every 2 months complaining. Almost every single one of my patients have been very happy that they've done it, all of them. And it's because I set the expectations prior to surgery. And that is the most important thing you can do. You gotta tell them, there is a chance for small print when you're reading the newspaper, you're gonna need to put on your readers. Also, don't choose somebody who's like an engineer or an ophthalmologist or something like that where they need to look at a microscope. Because yes, the multifocal isn't exactly as crisp as a monofocal. But for the average patient that we're doing cataract surgery on, who is not an engineer or a microsurgeon, they're ecstatic about it. So, I give some reasons here why it's not necessarily a bad thing to give this physician a little bit more compensation. We know that, and another thing, some people will argue, it's going to increase OR time or reduce efficiency in the OR, et cetera. That's not true, because as we know, putting in a multifocal is exactly the same amount of time as putting in a monofocal. And really, when you're choosing your IOL, if you have the measurement read out on the A-scan, you just circle that one instead of your SN60 lens. Next slide, please. All right, so some people think it's not, sorry, go ahead.
I agree with you that this is a potential for keeping our organization solvent. But I disagree with you because there are 2 factors that are competing. The first thing is, in private practice, it's set up so that the physician spends very little time with the patient in dealing with it. They have they have a coordinator, a nurse coordinator who tells them about the lenses. The physician is separated from this whole process. So when something bad goes on or it happens, it kind of isolates from the surgeon from the outcome of the thing. The patients choose it based on what the nurse coordinator explains. And so basically they choose the lens with the nurse coordinator, physician puts the lens in. There's very little chair time associated with that. But when we have to do something like this ourselves, I see it as, especially when access is a big issue, I see it as an access breaker for me. I see a lot of patients. Yesterday I saw almost 50 patients. If I had to fit in pre-ops with multifocal lens consults, it would have killed me. It's impossible to do that. So if somehow the money that we have, or that we get from this increased revenue, we could set up some type of lens counseling programs where the physicians are separated from this process, I would be all for it. But if we have to do both the counseling and the post-op management and also deal with all our bread and butter ophthalmology problems, it's not going to happen.
It's a great point. 2 things to answer that. Number 1, we should be discussing a multifocal lens with our patients because they have the right to know that option exists. Okay, so, and it maybe increases chair time a little bit, but I think it would be a disservice to not mention it, and then they come back and then they find out that there was this other option and they never heard about it, and that's kind of a conundrum there. And then number 2, honestly, when I go through, literally it takes maybe 30 seconds extra, at least for me, when I'm talking to my patients about this lens. It's not, I just literally say, because we already tell them, or at least we should, hey, you're gonna, this is what we expect for your refractive outcome, right? We talked to them about refractive outcomes already. That you're gonna, hopefully we're aiming for distance, do you want to be for near, et cetera, monovision, whatever. So we're talking to them already about that, and you just say, that by the way, there's this other lens that we can put in your eye that lets you see up close and far away. It's not perfect, it's not going to make it so you don't ever need reading glasses, but it'll make you much less dependent on glasses for reading. And then I give them the example of the cell phone and the can of soup. Okay, you're not going to need this, you're not going to need to put on your readers every time you grab your cell phone or every time you go to the store. And I tell them the price, and I say, no pressure,